You're back at the Sacred Birth Circle. Thank you for joining us. Today's guest is actually our first male guest on Womb Wisdom. He has delivered countless babies and helped so many of us understand the complications in our pregnancy that led to a loss. So I'm very happy to have him here with us. Please share this on social media to reach more families. Welcome to the Sacred Birth Circle. This is Anna Vick, and today I have the privilege of speaking to somebody who many people in our community of lost families have gotten to know, sadly, because of the issue of cord loss, which is, not very discussed or even understood. And a lot of times when you lose a baby to stillbirth, we don't get answers, and we're told that, sometimes it just happens and we don't know the cause. So that's really difficult for a family who has experienced such a tragedy. We just want to understand, what had happened. And my own experience with loss, I got that usual, really, apathetic response, which was sometimes healthy babies just die. And to me, that was just unacceptable. For me, it was really difficult to move on without a cause of the loss. So I did have to, though, for many years because no one was helping me. I just couldn't figure it out. I'm not a doctor. Eventually, I did get some information from Dr. Kleiman, who does pathology on the placenta, and that led me to understand that there was cord compressions involved with Owen's passing, and this happened for several days prior to the loss. So for me, it became another series of searches as understanding cords and cord accidents, I call it, because for me, it's not very accidental. I don't feel like we're doing enough in terms of even watching the cord and making sure, where's the position, how's the flow, especially if you're in a low risk pregnancy like ours was. So I'm bringing on Dr. Collins today to share some of his wisdom. And why don't we let you just go ahead and introduce yourself, a little bit about your background, and then we can chat.
Most important part of this is that I'm a graduate of Tulane Medical Center and practiced solo OB for almost 35 years. Probably have a very good record of delivering about 3,500 babies. But what struck me in that process was I had 2 term losses due to cord pathology. And it was very surprising to encounter these babies and try to understand what it was that was not being detected by usual prenatal care. And over time, it became apparent that part of the problem was just sheer education, that the topic isn't discussed anywhere in professional meetings, and that there's very little understanding about these pathologies. So pursuing this for quite some time, it's become apparent that this is a very common cause of stillbirth, and that there are over 20 different umbilical cord pathologies that are described in the pathology literature, but are really not discussed in the OB literature. So part of the problem is just a lack of knowledge, knowing how to identify babies like this, and then taking it seriously that these things can be due to cord pathology. So going back and looking at a lot of material all the way back to the 1600s, a lot of this is described in older literature. And as a matter of fact, there's a Dr. William Smellie from Lanark, Scotland, who described a lot of this and put this in the first edition of the Encyclopedia Britannica and drew pictures of these cord issues in the encyclopedia. He was a co-editor of those editions, which were published out of Edinburgh, Scotland. At the time, Edinburgh, Scotland was quite a center of education and innovation in its day. So a lot of those original drawings from that encyclopedia are at a museum in Lanark, Scotland, which is where Dr. Smiley, which is the right pronunciation, but it's not spelled like that, is buried in a very unique tomb in that small town. It's a very interesting place to visit. And that library is very intriguing when you go and you look at his books and drawings. So you hear a lot about umbilical cord issues being rare, and the fact of the matter is they're not rare. They're actually very common. And the rarity process that you hear is because they take individual cord issues like true knots and find out that there may be 2% of pregnancies, and they say, oh, it's rare. Well, that one particular type is, but when you add them all up together, 20 plus different pathologies, it's not rare at all. Matter of fact, there's some recent reports on stillbirth, one out of Italy, that puts it as a 30% cause of stillbirth. And there's another American study uh, out of Utah that says it's 20%. So the numbers change depending on what pathologies you're including in your study. And as best as I can tell, there is no stillbirth study that includes all 20 pathologies. So I suspect if you put them all in a bucket, it'll be a significant cause of stillbirth, but you got to go looking for it to be able to know that's what took place. And when these babies are delivered and they're not alive, people are in a hurry to bundle them up, and they're not paying attention to these details. So the details of a pathology or an operation never enters the delivery note or the descriptive note unless they're turned over to pathology and it's included there. So those elements are not in databases. So when they go to do stillbirth studies, they don't pop up because they're not in there in the first place. So what this all means is, I think that umbilical cord pathologies are a very common cause of stillbirth, and that when these are unexplained cases, that more than likely they weren't looking at the details enough to realize what the cause was. So my message is that these are very common causes of stillbirth, and it's my job is to try to encourage the OB community to start talking about it and presenting the information in CME conferences so that OBs can learn what to do. There was a young lady wrote me an email last week that was having decreased movement, went to the hospital. They monitored her for about 30 minutes. They thought they saw a couple of heart rate changes, but they decided to keep her, but they took the monitor off. So she stayed there all night and wasn't monitored. Well, that didn't do any good. So the next morning, the doctor went to make his rounds, listened to the baby's heartbeat with a Doppler, which doesn't record the trend, and let her go home. And the next day she showed up with a dead baby with multiple cord pathologies. So they never thought to take a look at this baby with ultrasound to look to see if there was something. As it turned out, she had a true knot, cord around the body and 2 cords around the neck. If you had seen that on an ultrasound, well, you would have monitored her on a continuous basis to see if there was cord compression. And that would have probably been very obvious. By doing that, she probably would have a live baby today.
Wow, that is so shameful.
Yeah,
I mean,
it's
it's
a
tough
sad
being a
case.
parent because we trust the provider, and I don't think that that patient had any clue, that it would turn out this way, of course. And, being there, she felt safe. And it's just sad, I do think it's very bad amongst most providers to think that the baby's healthy as long as there's a heartbeat, because it's plain and simple that that's not the only thing. And the heartbeat will continue until the baby is dead, unfortunately. So they need to look further if there's a movement change, than just simply the heartbeat. That's horrible.
Another issue came up. She went back and asked the nurses why they didn't keep the monitor on her. And the nurse said, you could do too much monitoring. And I told her there was no such principle. There is no such idea that you can use too much monitoring. Monitoring doesn't hurt the baby. I've monitored moms for weeks on end, continuously, especially if they had twins. It doesn't do a thing to the baby. So these are myths. When people don't want to be bothered with monitoring because they got to watch it. So if you're in the hospital and you're concerned, you tell them to put the monitor on you and don't take it off until your doctor sees it.
Oh yeah,
Uh,
I did that with my pregnancy after loss because at that point I realized that babies do die. And if they're healthy and well one day, it doesn't mean anything. In the next hour, something else can happen. So I had that monitor on the last week because of the low fluids. And I actually wrote in my journal about it. I was saying, oh goodness, if there's low fluids, that cord can get compressed. And I don't know what I was researching to even think that because my doctor didn't mention that at all. That was my own kind of belief that if I don't keep an eye on my second son, that might happen again. But at that time, I didn't even know that that was really the reason that his
Well,
brother.
that's a known element. There's a paper published by Dr. Mercer who talks about low amniotic fluid and the risk of cord compression. So that idea has been published, and it should be information that OB is familiar with, that low amniotic fluid can be a problem and you got to pay attention to it.
Mhm.
So these ideas are out there, they're in print. It's a lack of knowledge that is causing some of these things to take place because of a lack of awareness. So it's up to the moms to be educated at this point, which is what I'm rooting for. Teach the moms how to protect themselves and how to demand these testings and observations so that they don't get turned away by a myth. Go drink a Coke and you'll be fine. These are not things that should be happening.
Right. And that's one thing that we've been meeting with other parents every first Friday of the month. So if anyone's watching had a cord loss, please send me an email, anna@pushpregnancy.org, and we'll send you the Zoom link. And we've just been hearing each other's stories, and Dr. Collins has been kind enough to join us and giving his feedback of what happened with our loss and also what we should all do moving forward if anyone's wishing to be pregnant again or just to advocate for other parents, which is what I do because I'm not planning any more babies, but I don't want to see people losing babies that are perfect. The health of the baby is most of the time very perfect until this cord trauma starts to happen. And then, there could be even babies with deficits being born that could be prevented as well if we were just paying attention a little bit more to this cord issue.
Some uh, OB practitioners don't think core compression can cause death. And this has been clearly proven in animal model studies, where if you have intermittent core compression, like 50% compression every 3 minutes, the babies are going to develop heart arrhythmias, and then they'll just stop beating and the babies collapse. So it's like a marathon runner. So there's no question what the mechanism is. It's not a mystery. It's very obvious these babies are getting into trouble with their hearts when they're having consistent repetitive core compressions. So they can look fine 1 minute, and then the next minute they're going into these mechanics and it's causing them to collapse.
Hmm.
So a lot of these moms have had biophysical profiles and NSTs like in an afternoon, and they come back the next day with dead babies.
Right.
Well, that's why, because they weren't watching it at the time where it would be most obvious, which we've learned is bedtime. Bedtime is the best time to monitor these babies, not during the day. So if you have uh, a reason to think your baby's not moving or behaving as usual, well, then go get monitored. And if it's not clear the baby's okay, then insist on staying overnight on the monitor and don't let them take it off of you.
I agree 100% with that. I think there's actually statistics on stillbirths occurring mostly a lot in the evening at late hours. And it could have to do also with a mother thinking, well, I'm going to go to the doctor in the morning anyway. So, none of us really know about stillbirth until it happens to us. So we don't have that urgency. If a doctor never talked to you about fetal movement, what to do and how you should be kid counting for every pregnancy, regardless if you're a low risk pregnancy or all these things come into play. But I think, yeah, the fact that you just said that it can happen a lot at night too. It's just, that's why I tell people go right in, don't wait for the morning. Don't think about it. Don't start kick counting then. Because if you already felt a change yourself, that's your intuition, and your baby feels different. As a mother who lost the baby this way, sadly it was cord compression, so it was like he was getting weaker. And so when I noticed it, it was like my whole stomach was limper. It wasn't as he wasn't, his muscle tone wasn't there, sadly. So that's something that you would definitely feel a change. So just trust yourself and go as fast as you can and get there. And like you said, stay on the monitor, because a monitor, once it's off, it's off. They're not going to know what's changing in there, and your baby can behave really well just for the NST, especially if they give you juice or something, which a lot of nurses still have the habit of doing. And we're working on, just a re-education of everybody on this fetal movements issue, because even they have misconceptions. They might tell you, oh, it's just because your baby's ready to get born, don't worry. And that's not necessarily true. There could be an issue with the cord. And not getting the nutrients as it should. So we did have a question from our live chat asking if a provider is unfamiliar with these protocols to check for cord abnormalities, what should you do? Like, how can we insist on these checks to be done? And
Well, what we've done is if a mother is experiencing a change in behavior and she asks her OB for an evaluation and to include in the evaluation a view of the cord position and they're denied, we recommend they go to a local ultrasound boutique, which is actually inexpensive compared to the hospital, and ask them to do the study and look at the cord position. We've actually done that a number of times where we've actually found the entanglement and brought the pictures back to the doctor at the hospital to say, baby's not moving, here's the problem, you need to admit the lady to labor and delivery and pay close attention to it. So if they won't accommodate you, then go to a boutique ultrasound and I guarantee you they'll accommodate you. They'll be more than happy to look at the baby.
so go into that a little bit more because you have talked about this being possible. Like we can look at the flow and all this, the position with the 3D ultrasound, right? Which is what some women get, those 3D or 4D even, to get a better view of what their little baby's looking like. So we obviously have the technology. There's the science out there. The doctors are just not using it. So what is the problem? Do we have an issue with doctors just not wanting to see it and go further and have to fully, be responsible for a baby that now has an identified risk? And they might have to make a call to deliver early, or what is really the problem? I mean, you were a doctor, you knew, in your case, you obviously wanted to save every baby, so you wanted to see this, but some people are almost not wanting to see. So what do you think? What is this mentality?
Well, it's a concern of several types. Some people, when I ask them, figure there's an increased cost of testing, but that to me is not an issue when you're trying to take care of a baby. The next part is not knowing what to do with the finding. What do you do with a baby with 5 loops around the neck? Well, what you do is you put them in the hospital and you put them on a monitor and you watch them 24/7, uh, which is what a doctor did in Arizona recently. He saw the 5 loops, he documented the 5 loops, but he didn't admit the patient and she lost the baby 3 days later. Didn't tell the mother she had the 5 loops either. So these are just areas of lack of education that need to be changed. But if you are at a boutique hospital and they show you entanglement, then you insist on going to labor and delivery with the pictures and tell the doctor involved, you need to pay attention to this. And then, say, I want to be admitted and I don't want to leave until everything looks normal.
I think that is really absurd. The whole idea of, oh, if women know all the information, then maybe we'll have to do more and it'll cost more, or they're just going to panic. But I don't think information will lead to that. I think it'll make us more alert and aware of what could potentially go wrong in a pregnancy. And, the fact that stillbirth occurs more often in a low risk pregnancy and also in a first time mom's pregnancy, that's very telling to the nature of this problem with, providers perhaps not even listening to the concern when you come in and, dismissing it or just quickly addressing it with the heart check and, oh, well, your baby's fine. Go ahead and go home. You're just worried, your baby's almost coming. So I think there's a big, it's kind of the paternalistic nature, of medicine. And I'm not saying it's just the men because women are also obese and have that same attitude. And then, first time mom, it's really hard for them to come in and be demanding of something that they don't even really fully understand. I've done all the research now because I lost a baby and I'm like, oh my God, what's happening? So I feel like I can come in there and demand certain things. But, for another mother, and when I lost my son too, I just didn't know what else to say. If the doctor told me everything looked fine, what else was I going to say? So we really put that trust in those doctors to do fully everything possible. And that's so disappointing when you lose a baby to find out that they could have done more and they just didn't.
Well, the most important thing to say about all that is if you think you have a problem, don't ask permission to go to labor and delivery, just go. You have every right to go to labor and delivery. You don't need a special prescription or authority to say to go. You just go. Labor and delivery units are like pregnancy emergency rooms. You just go to the emergency room if you think something's not right. And then when you get there, you just make it clear you're having a problem and you expect to be evaluated. Once you're there, they have to evaluate you by law. So just go ahead and step into the environment, say, I'm having a problem, and they're supposed to do what they're supposed to do.
Hmm. So in most of these cases that you've heard, is it the fetal movement that gives the mom the feeling that something is going on in there, and you
Yeah,
think that
usually,
might give
or
them time?
they have contractions.
Hmm.
Uh, so yeah, those are two most common reasons to go get checked. There's nothing wrong to go get checked, and nothing wrong with being checked every day. If you're having problems and you get checked and they send you home and you're still having trouble, go back. Go back as many times as you want. Don't be shy. You know, it's the only way we have to find these babies and get them out of trouble. We don't have any special instruments or means to go and evaluate the baby's blood or oxygen status at this time. But I suspect in the future we'll have some very sophisticated sensors that you'll be able to use to tell these things. We just don't have it right now.
No, and I think the demand needs to be there, like we were mentioning, mothers just demanding more care, and that we don't have babies slipping through cracks that are perfectly healthy, into the third trimester. And that's when we start to see these problems. And they're viable age. So, delivery can happen. And, our NICU, all of that technology is pretty good now where we can keep babies alive that are very young. Like my son, he was under 32 weeks. So I didn't suspect, I was ever going to deliver at that time, but it had it happen and had it been done well and quickly, like it was a crash C-section, but there to me were a lot of things done improperly to resuscitate preemie, and he had had damage for several days. But I think that he could have lived, in the NICU. He was obviously bigger. This is actually
Oh,
my son's size, so
oh, wow.
I have him here to demonstrate he's the length and the weight. So he was a big boy already. So that's why the doctors worked on him so long. They said, we have smaller babies survive. So, but that's to show as well the cord damage, the cord trauma, like being hypoxic or having multiple incidents of this cord compression did enough damage to the organs that he just couldn't be resuscitated. And who knows what quality of life he would have had. So,
Well, in the future, it just uh, to show there's hope, uh, they'll make sensors the size of a grain of rice. And what they'll do is they'll take a baby that's having trouble, maybe he's not growing enough or he's not moving enough, and they'll inject that little grain of rice into their thigh or their butt, and it'll send out the oxygen level and the pH level of what the baby's doing to an external monitor, and you'll be able to directly monitor the baby and see what it's doing. So those things are going to come down the road. Uh, they have facsimiles of these type of things already, um, and we'll be much better able to track a baby that may be having difficulty and get to him before it becomes fatal.
wow, that's amazing. And it's hopeful. Like I feel like I'm stressed over this because this is the reason my son died. So, when I talk about it, it's just very frustrating for me because now my pregnancy after loss, I saw the greater level of care that's even available now that I didn't get with my son prior. So it's really like I'm angry because had I gotten the care that I could have gotten, he could possibly be here. I think my other doctors would have been monitoring much more. And I had NSTs with my rainbow baby every week. I think I ended up with twice a week at the end. They look for so much more and they're capable of this, but they're not doing it for every pregnancy. They're only doing it for the high risk. Once you become high risk, is either you lost a baby or you've been identified as having some issues that might cause a loss. But it seems just very unfair that we're stratified in that way, where I feel like everyone's a risk, for stillbirth. Of course we are, we see it in the statistics that these first time moms and low risk moms, we all are having more stillbirths. So this whole idea of saying, oh, you're low risk, so you don't need that, that's to me ridiculous, you know.
moms have to be taught to be aggressive, that if they don't feel right, to demand an evaluation. And, we're limited as to what we can look at and see and measure, but getting the evaluation is a good first step in trying to prevent these issues from happening. So uh, you can demand these things, and if you don't uh, get the evaluation you need, go to another hospital.
So what
Keep
are the
going, get what
actual
you need.
tests that you suggest, like with our current technology, that a mother, especially after a loss due to a cord accident, what should she ask of her provider to be doing? Like when should they start looking at the cord and how, you
Well,
know?
they should start at 20 weeks when they do their anatomy scan and they're looking for congenital anomalies. They should be looking at the cord from its attachment in the placenta to the attachment into the baby, because there are pathologies at the belly button that need to be recognized. And so once you get past the 20-week phase, then they should be looked at again at 24 weeks and then looked at again at 28 weeks. These are the moms that have had a loss. And then they should be looked at every other week with ultrasound, and they should be getting heart rate tests twice a week after 28 weeks, looking for heart rate changes. So it's a lot of testing, but that's what it takes. That's what we have today in the way of science to be able to find these things. So we have to do it frequently to have a chance of finding it. Every 4 weeks isn't enough.
Yeah, and especially if, for instance, like a restriction of growth is noticed, like the fetus isn't growing normally, that should be something immediate. They start looking at the cord, and I'm sure they might. Maybe that's standard, but I think if your baby is looking normal, though, it's really tough to get these extra things. So, what would a mother who hasn't had a loss want to start asking? I mean, they feel like they probably are getting the care they need, but we're going to say, no, you probably aren't, because a lot of the mothers that have had a loss to cord knot and all this is just their first baby. So,
Well, uh, again, they just have to learn to demand what they want, and they either win that argument or they don't. But they tell the OBs, "I don't feel comfortable with what's going on. I need you to look at this baby more." And
mhm.
hopefully, the OB will realize that there's a concern, and they'll accommodate the patient.
Right, because I think the problem also runs into insurance maybe not covering additional scans and things for a low risk mother. So I think one thing we can say is if you do start to be noticing the change of movements, that's an immediate need to go in and get scanned. So you should go in right away, get that done. And then again, if you're not comfortable, don't leave that until that, next morning if you want to stay overnight and get at least one night of monitoring. I think that's really smart. And then further continue to see how you feel, because those scans again can come back normal, and then you're still like, no, baby's still acting different than normal, then you need to go back in. And that's like that persistence that you might even feel like you're doing, you're bothering them too much, like, oh, I just went in yesterday, I'm just freaking out for nothing. And I just want to tell you, it's not for nothing. This is so important for you to feel like supported in your decision to go back, because some people, maybe it does cost you money each time you go in and you have to do a copay or something, but at the end of the day, you want your baby alive and here. And all of this pregnancy, like I paid for my entire maternity care for my son Owen, plus the delivery and everything, and I have nothing to show for it. I don't have my baby. So you want to have your baby, of course, born alive. And so if you go in a few extra times, it'll be worth the money. I would pay millions now for my baby to be here.
Yeah,
So,
you can never go too much. There's no such thing as too much.
yeah. Yeah. And it's hard because I think a lot of the mothers who lost children to the knots or the nuchal cords and that sort of thing, there's a lot of conversation right now, especially with natural birth communities, where they think, oh, nuchal cord means nothing. So many babies are delivered with one and they're just fine. They survive it. And yes, it's true. I think it's a survivor's bias, though, because we don't know if that baby was at the brink of danger. The baby's alive, so of course you can say that, but had the baby passed away, then we would all be saying, well, why didn't anyone do anything about it? They had it, the cord around the neck. And, we see that with a lot of losses where the mothers are now like, how come my doctor let this go? And it was obviously there. And I think even ACOG has said that the cords and even a knot is not considered a cause of a stillbirth. So, that's really complicated too, because there's this, I would call it misinformation. I don't know what you would call it, but I feel like a lot of people are judging, nuchal cords and things like that as not very dangerous.
Well, I just call it misunderstanding. Um, they don't understand how it works. They don't understand how it can cause death. And babies born with nuchal cords, they're not all the same, because the puzzle is just not the cord around the neck. The puzzle is, where is the cord attached to the placenta and where is the placenta? So there's much more to the puzzle than just the cord around the neck, including the structure of the cord itself. There's 8 different cord forms. So which form do you have? Do you have a thick one or do you have a thin one? It's called thin cord syndrome. So the babies that have cord loops that are born without a problem probably don't have the umbilical cord under tension. They probably have placentas that are more toward the cervix, which provides relaxation of the cord length. All the lengths are not the same. They can be anywhere from no length to 300 centimeters in length. So you can't compare cord loop to cord loop because they're not the same. So the ones you're looking for are the ones that have the combinations where you create tension on that loop, and the baby, as it descends, gets its blood flow cut off from the descent, because his cord is only 30 centimeters long and it's attached at the top of the uterus. And once you get a cord around the neck, you've been reduced to 20 centimeters long. It's a relative shortness, and you'll create tension on the descent of the baby. So you can't say they're all the same, and you can't say, oh, this one didn't cause a problem. If I were to get the details of those babies, I could tell you why they didn't cause a problem. But I can also tell you the ones that did cause the problem and why. So it's an inaccuracy to compare these babies to each other because they're not the same. The nuchal cords are not the same. So it's a lack of understanding of how this works.
Right. And it also fits the rhetoric. I mean, if you're trying to encourage everyone to birth naturally and make them not be fearful of having a birth without any interventions and any kind of scanning or anything happening, then of course it's better for you to say, look at this baby that I delivered with the nuchal cord and I just slipped it off and it was fine. And so everyone will be fine and hardly ever, at risk of death. They don't even I don't even know that they even mention the word stillbirth is, potential risk in those type of posts that we read. But, they try to make you look the other way, like, look at the baby's alive. And you're like, even if that's true, that a lot of them can survive and they're okay, like you said, there's certain ones that won't. And how horrible for that mother, and that father, that, wow, we could have done something here and we should have been inside of a hospital, not trying to home birth, or wherever you are. It can happen at the hospital too if they're not looking. But to me, it's really tragic. And for people to look at statistics the way that we do, where you're like, oh, it's pretty rare, like, well, even just one child, that could be your child. And it was for me. So for me, it's like, let's not look at the statistics so much as the facts. And like you mentioned, like, let's look at all those details, how long the cord is, where is it positioned? How is this baby trying to come out? And oh, it's just so much. And I'm like, it's pretty obvious when you say it, to be honest, Dr. Collins. I'm like, you break it down in a way where I understand. I'm not a doctor and it just makes so much sense. So I find it strange that people would even go against that.
Well, they don't want it to be a problem because they don't want to have to deal with the problem. But it's taken me a long time to understand the problem. And I guarantee you, most of the people doing these studies saying nuchal cords aren't a problem don't have a comprehension of it. And so their studies come up lame because the way they look at it is so inaccurate. You can't do a study of nuchal cords just looking at the nuchal cord. You got to look at the whole puzzle, or you won't get it right, and you'll come to the conclusion it's not a problem. But it is a problem because what they didn't tell you in the study are the babies that got delivered early because they were having difficulty, and they don't really go into the C-sections they did during labor because the heart rates were changing, and those babies had cord entanglement. So that gets wiped from the database, so you don't see it in the ultimate report, which looks really pretty mathematically, that everything uh, was statistically proven, and oh, we didn't run into a single problem. Well, that's funny because I hear about your problem every damn week. People losing babies to this, so you're missing something, and I know what they're missing. But to try to explain it to them is very difficult to do. They don't want to hear it.
Can you actually notice like the length of a cord
Oh
while
yeah,
oh
yeah.
wow.
We're the first ones to do it. We published that years ago that we actually measured the cord length in its entirety with ultrasound. In the earlier ultrasounds, they used to have these calipers where you could draw along the cord and it would come out with a total length after you finished drawing it, like an etch a sketch. They don't have that anymore. But yeah, you could tell if you have a long cord. There's a simple way of doing it. I learned it from a Harvard ultrasonographer, Dr. Jason Bernholtz. You just look at it. If you have a cord that's long, then the picture's going to look like spaghetti. If you have a cord that's short, you won't see it when you look. So it could be that simple in figuring it out.
Yeah, and I mean, we're not holding them to knowing the exact length, even though like they try to know like the size of your baby and that's usually we know it's usually a little bit off. And a lot of people in the community of these natural birthers too joke about, oh, you don't have a big baby. They have no idea. The baby's born and it's much smaller, you know?
Yeah.
So even with the cord though, I mean, it is important for me, I would think, to know that if there were like, okay, we see a new cord and we want to know how much extra length is left over, you might want to look at that to see if
Yeah.
it's not going to tighten, to an extreme. And I mean, I wouldn't be comfortable as a mother if someone told me that there's a nuchal cord situation happening in the pregnancy and then they weren't going to do anything about it, because they don't think that that's necessarily a risk. So, what would a mother want to say at that point? Because for me, I'd be like, get my baby out, but it depends on how early it is and, what they can do.
The obligation is if they make an ultrasound report that the baby has entanglement, they ethically have to tell the mother of the finding, and they have to educate the mother. Look, we noticed this, so be aware of your baby's behavior. And if you notice a change, you need to come back and let us look at it again. That's what they're supposed to do. They're not supposed to ignore it. They're not supposed to tell the mother, we're not worried about it. They're not supposed to suggest that there's no harm in it. All that is unethical. That shouldn't even be happening.
Well, yeah, and what you just said is actually what I know is happening because unfortunately, like you said, all these mothers coming to us telling us their story, they're all coming to our meetings on the first Friday of the month that I mentioned, and they write me a little blurb of what happened. And they said, my doctor didn't even tell me there was a true knot or a nuchal cord happening until it actually turned into my son or daughter dying, and then it was mentioned. And I'm like, why didn't anyone mention it to me? The parents should at least be informed and be able to advocate and like, well, let's be on a monitor. Let's do something more, deliver me if I'm at 38 weeks and few days.
Yeah, that's what should be happening, but we're just not in a point in time where that's understood. There's too many aberrations about making the mother 39 weeks, or the idea that this doesn't cause a problem. They don't want it to cause a problem because they don't want to be held accountable for it, but it does. I mean, the last 300 years of literature is full of examples where it does. And I mean, the most obvious example are twins in the same sac called monoamniotic twins. They're known to uh, be entangled and have knots and to die around 32 weeks. So they're usually delivered right at that time. So it's interesting that with that experience over time, that monoamniotic twins that were entangled were all delivered early, that they would insist that these things don't cause a problem. It just doesn't add up.
So myself and others have had this diagnosis of the loss being caused by cord compressions, and some of them have a small placenta. And mine actually had a large, which I don't know what that even means to have a cord compressions and a large placenta. For me, the small makes sense because it means maybe not enough is going to it, and it stops growing. But do you see correlations like that too with the placenta? Because we aren't fully monitoring the placenta either. And maybe that should be another area, like we're trying to get the EPVs done for measuring of a placenta, you
Yeah,
know.
I think wherever you have evidence of poor blood perfusion in the placenta, that you're probably going to see cord issues because the baby is going to reflexively respond to that blood flow volume because his tendency is to want adequate blood flow. So I do think that a lot of this is caused by the baby's reaching stages of development where it says, I need a little bit more, I need a little bit more, it doesn't get it. So it reacts by maneuvering around the womb, which is what ultimately leads to the entanglement or the torsion or some of the other things that can happen. So yeah, there is a connection, I believe.
Hmm. What happens with the cord compression? Is there a simple, like the baby's pushing on it, grabbing it? Like, what is making the cord compress? Like, that's something I keep going back to because I'm like, my son wasn't full term even yet, but I know it does happen in bigger babies that are almost ready to be born. So I imagine like he must have had a lot of room in there. I do now that the placenta was large, so maybe that took some of the space. But what is causing cord compressions?
Well, it's a number of things. The baby can grab it, he can suck on it, he can get it caught between his legs, he can get it caught under his arm. Uh, uh, there are all kind of places where his shoulder or his hip can sit on the insertion, or his head can sit on the insertion and cause an interruption of blood flow. All that's possible.
Yeah, so that's one thing where it boggles my mind because I'm like, we all are taught like baby's safe in the womb. It's the safest place for the baby. There's plenty of space, of course. There's, the amniotic fluid around the baby as long as that's measuring normal. You're not having, leaking and stuff. Like it's so tough for a mom to feel like all of a sudden you're like, oh my God, he may not be safe in there. So I think, anecdote to that is definitely just kick counting daily, trying to get to know the normal pattern of your baby, paying attention throughout the day. Like, when does your baby get really active? And, noticing that if it changed one day, like even more frantic, which I think is also part of the research of frantic change, might show like cord compressions are happening. Is that something that you hear a lot too? Because that's something that
Oh
we're,
yeah, we've done easily over 1,000 lost mom interviews to cord accidents, and the idea of the baby being hyperactive is a common theme. So yeah, I think what this all means is babies operate off of reflexes, just like you blink your eye if you get dust in your eye. And if the baby is having difficulty with blood flow, he's going to react to that by maneuvering. He's going to kick around, roll around, spin around, and it's just all based on reflexes. The babies are not completely awake in the womb. They're actually what we call semi-comatose. They're really not awake. And so that they operate off of reflexes because nature built that in so they could protect their blood flow, especially from the cord. So if you just think about it in terms of nature, it makes a lot of sense that that's the way things operate.
yeah, Dr. Kleiman talks about it like scuba diver, and if all of a sudden that's getting smushed, the what do you call that? The tube you're breathing out of, you're going to start to act a little bit different and, flail a little bit. So when I talk about increase of movement for a mother to pay attention to that, I don't mean just like, oh, he's getting a little more active over time or anything. It would be pretty obvious. It would be like a mad kicking to get out of position, like you're mentioning, and, try to get some air because he's unfortunately becoming hypoxic in some way. So,
Yeah. So, any extreme of movement, whether it be diminished from what you're used to or hyperactive from what you're used to, go get evaluated. I mean, in the past, I had OB patients saying, my baby just won't stop moving. Well, there's one right there. If someone tells you that as an OB, go get that baby evaluated. There's a reason he won't stop moving. Okay. And the chances are that he's uncomfortable. That's the word I use. So instead of saying he's hypoxic, because I don't know, I just say he's uncomfortable for some reason and he's reacting to it. So some of the examples are mama's telling you they'll be sitting on a sofa sideways and the baby will start kicking the hell out of them till they change position, and then the baby settles down. So whatever that position was affecting the baby's blood flow, and he was telling the mom, cut it out. I don't like the way you're sitting. So there are things in nature that are protective, that are designed to protect the baby. And I think you can see that a range of different animal life. Uh, so these are things that we have no way of directing. Reading about instinctive behavior or why we do what we do. But if you think of certain animals like kangaroos, those embryos crawl out of the womb of the kangaroo. They don't have placentas and cords, and they crawl outside into the pouch of the mom, and they actually have a very sophisticated milk production system, and they feed off the milk in the pouch for quite a long time. So if a kangaroo as an embryo can climb out of the womb into a pouch and find the source of milk, well, why can't you have other mechanisms to protect the baby exist?
Hmm. That was like a cute image I was just looking at in my mind of the kangaroo. So here's a good question. So are cord accidents truly unpredictable? Is it possible to have multiple daily NSTs and weekly BPPs um, showing everything is fine before loss and then something just happened really fast? Or is it more likely that something was missed, which
I,
was the
I,
case
I,
with the
I
last few things?
just doing this, I don't think they're unpredictable. I firmly believe they're clearly predictable. But you have to know what the puzzle looks like. You got to get in there with ultrasound, and you got to look at all the elements. And if you see a puzzle that has a configuration that looks at risk, well, then there's a possibility. So you start watching the baby for that possibility, and the baby will show you that it's getting into trouble. They just aren't healthy today and dead tomorrow. They will show you they're having a problem. And you have time to find the baby in trouble, because I've done it, and I've done it more than once, and to get to that baby before something happens to it.
So I think the problem though is the NSTs. I'm not sure the BPPs, but do they even check cord flow and position and length and the knots? And is that all included in what you would get normally? Like she mentioned, she was
No,
getting
no,
those.
none of that is done these days.
So that's why I go cord accident, because I don't believe accident can be put around, a word when you're not really watching it. It's not accidental. To me, my son was not being watched. It's like if I would let my other son run across the street, that would be my negligence as a parent. And that's where I feel so angry, because I feel like my doctors weren't watching my other son in the way that they should have. And maybe it's not truly their fault, because protocols for ACOG don't include this. So they're not being told this is not standard of care. So I am working with that as well. Like that's our eventual goal is, as our group starts to discuss more and more, to talk with ACOG and say, listen, we get it. This is standard right now, but what can we do more? Because obviously we're not preventing deaths, and we're allowing babies to die, healthy babies that could have been born. And many of them, I know so many that are on their due date or further, that could have been delivered just one day sooner. And that baby would be alive and well, and this family wouldn't go through this lifelong trauma that we all are going through. It's not just, oops, well, we're so sorry, the accident happened. Next time, this is what we're going to do different for you. And now you're going to get your baby. It's like they think it's a try, like, oh, go try again. It's not a failed pregnancy. This is a baby that you just let die on your watch. And that's why I was so furious after, because they wouldn't even discuss what caused it. And I'm like, how can you make me go through a whole pregnancy? And, I was in your care. I even went to you when I noticed the change, and nobody communicated with me, told me that anything was going on with his heartbeat plummeting the minute I got there. My husband wasn't with me. I was by myself. I went to the ER just thinking, oh, I'm just acting a little too concerned. I just want to check on the heartbeat. And that's all I thought. I was going to check the heartbeat and come back home. I mean, who expects this at 31 weeks? And then be told once, the doctor on call arrived, he said, "We're bringing you in for a C-section," and I was like, "My husband doesn't even know, he's not here. What do you mean?" Like, so I had to call him on speaker as they're like dragging me in to be cut open. It was like the most traumatic event of my life, and I don't understand how doctors don't communicate more with those situations. Like immediately, when I arrived, his heartbeat was already low, like at 80. So they
Yes.
could have said, like, "Hey, call your husband. This something's going on tonight. Was might be the night you deliver this baby." Like anything. I would have loved to been able to tell my husband to be there at my side before. It took a whole hour for the doctor to get there on call and have it all set up for the C-section. And so all this while I had no knowledge. It's very disrespectful. It's like they don't respect my humanity. I'm a person that trauma is just with me forever. And the fact that like my husband wasn't there, he didn't get there till they had already brought my son out and they were resuscitating, and he had to see all that. It was just such a shocking, horror. But all of that just to say is like there could be more being done in all aspects, but especially communication with the patient, you know, letting me know what's going on here. Your son's heartbeat is failing, the first thing, like get me prepared for what's about to happen. Yeah.
Well, those are important things, and it all has to do with uh, making it clear what you're doing, and uh, by getting the topic into discussion, a lot of that will correct itself. So what you're doing is very important to get ACOG to start talking about it. What I'm trying to do is get them to start talking about the pathologies. I'm not even at a point where I can convince them you can do something about it, which you can. So if I could just get them to acknowledge that the pathologies exist and that they'll start having CME on umbilical cord pathology, that'll be a step forward, because once you get them to accept it exists, then it's not too hard to get them to say, this is how you fix it. So what you're doing will get you there.
Yeah, no, we appreciate you too because, and we're not doctors. We obviously have learned through our loss about what happened with our particular loss, and we all dive very deep into as much as we can possibly read about, research. And I've attended every stillbirth conference, including the international one last year, and I try to learn as much as I can. I almost feel like I probably know more than a lot of OBs who learn like this much in school about stillbirth prevention, and then they may not experience one for a long time, which is why for them they feel it's rare. But when they finally do, a lot of them just chalk it up to, this is rare, this is like bad luck, it just happens.
Well, even the Stillbirth Alliance won't talk about cord accidents.
Yeah, we almost forgot to put it in our symposium, to be honest. We were like planning, and the last minute I said, wait, where's the cord research? And everyone's like, oh, yeah, that is important, right? So, and I was like, yeah, of course it's important. It's the reason my son died. So that's what we reached out to you last minute, and we try to get somebody new because we have had you before share. And we're just like, there has to be more people working on this, right? Like, this is so important. It's one of the main, I mean, I call it the lifeline. You call it the lifeline. I think I got that from you, but I'm like, how can not enough people even be interested in researching this? It was kind of hard to scramble to find proper.
There's a couple of them.
Yeah.
They're out there, and there are more people catching on to this, especially in India and China. So it's becoming discussed more than it used to. So people are publishing their case reports of making these diagnoses and how they manage the case. So it's out there. It's a lot of material. I try to keep up with it, uh, but it's a lot. So that's encouraging to see that.
Hmm. Yeah, I mean, it happens in other countries. So that's kind of the problem we're having, I think, with ACOG too, where they say, like, well, that's not US data. That's not US moms. We're like, well, what's the difference? It's the same biology. I mean, it's the same issue happening here.
Well, it's a thing out there. I've encountered that before about who's the best, and they don't acknowledge that other people in other parts of the world are very good at OB research. I mean, they've got some people in Great Britain who are superb, and then you've got some researchers in New Zealand who are superb. So it's just I don't know what it is. It's just I'm better than you. Our research is better than yours, but not really. In fact, I think some of the best researchers around are in Croatia. They have one of the more amazing groups that publishes neonatal research. I'm very impressed with those people. So they're out there.
Well, we're slowly reading them, trying to understand them. But I think what's more important really is all of us gathering together and saying, like, that's enough, 23,000 babies a year that are dying in such a big portion with cord accidents, accidents. I would do that every time I say it. It really doesn't make sense for us to keep waiting for research. We need to start doing something. And when you have the high risk doctors doing more, well, let's at least do that, until we get to the point where we can do what we really should be doing with, scanning the cords
Well,
for everyone.
keep talking to the moms. Once they learn the moms know, they'll have no choice but to do something about it.
Hmm.
As long as they can get away with the excuses, they will. But as soon as the moms can call them and say, that's just not correct, I know what you just said was bull, that'll stop it.
Hmm. So everyone who's interested, again, email me, ann@pushpregnancy.org. We'll be meeting Friday evening, and I always send meeting notes and the Zoom as well if you missed it, because we record that. But we're going to keep talking and we're going to keep pushing together. And I do think we'll see change, and it will be saving babies' lives, because so many of these babies were so close, and that's what's so sad about a cord loss. And as she mentioned, like, and the question, is it possible that it just happens so fast? I mean, it is a fast end, right? I mean, when it finally takes the life of the baby, it did happen quickly, and, too quick for the doctor to step in, but they definitely missed some things.
Just like the lady I told you about, she was in the hospital. But the mistake they made, what I call systems errors, is the nurses get this attitude that they can't sleep with the monitor on, so they take it off. Well, you're taking off the instrument that's the key to understanding what's going on. If you were in ICU, a cardiac ICU, and people were having cardiac issues, you're going to take the cardiac monitor off the patient? Hell no, you're not.
And I wouldn't allow it, and that's what I didn't do in my pregnancy after loss. I was like, you're gonna leave that on? That's the only way I slept, thinking about my fluid going low again. I'm like, are you kidding me? They had me on an IV to give me fluids, so they got me to normal again. And they said, you can go home, the next day. I said, no way, Jose, unless you like deliver this baby now. Like, my son was at least 36 and a half by then. I said, I'm willing to take whatever, if that means NICU for a little while, but I don't want to leave and have another baby not come home with me.
Right.
So I stayed, and the doctor said, well, let me see what I can do because of insurance. They're not just going to keep you here for no reason. But I said, nope, I'm not comfortable. And that's the only way I really slept, because there was no way I was going to go home. I was an hour away from the hospital. So for me to go all the way home and then start to feel fetal movement change, have to rush over there, come to the fact that who knows what would happen,
Oh, yeah. No, well, that was good on your part that you were able to insist. So
Well,
but some
sadly,
people are
it took me
shy,
losing a child, I wouldn't have done that, I don't think, with Owen, because I wouldn't have known to do that.
Right. Well, that's what moms have to learn. Mom's going to have to learn that they don't have to do what they're being told to do if it doesn't seem right for them, you
Hmm.
know. And the simplest thing to do is just stay on a labor and delivery unit and be monitored until you know for a fact your baby's okay.
Yeah, I mean, and even like we said, those monitors are faulty. So unless you're actually on it, it may not catch the compression and the
Right.
change.
Well, if you're sampling long enough, you'll catch it.
Right. Yeah, that's the thing though. They do them for maybe an hour normally. A lot of them
Yeah.
30 minutes if they get what they need.
Yeah.
So you do
I've
have
seen
to
some
say,
that they
no,
said were okay and they weren't okay at all. So
yeah,
it also is the person doing it, do they know what they're doing? No, they don't.
right. Oh no, I had a friend sadly that was having one done, and the BPP, the baby wasn't meeting all the marks, wasn't moving. So they had her jump up and down until she got some movement. Well, of
Yeah, see,
course, the baby's moving in
that
fluid. Like, what is this?
yeah, well, that's just totally wrong. You're not supposed to stimulate the baby if he's not moving. You're supposed to do the test in the allotted time, and if you don't have limb movement, then he didn't pass the test. But you can't force the movement to so you can say he passed the test. I've heard those stories lots, and then the babies come back dead in a couple of days.
Yeah. I
Yeah,
mean, it's
that's
not like a test where you're like, I want to pass this, just pass me. Like you're in a college class, like just pass me, pass my test, so I could go home. No, you want to know for sure that your baby is okay. That's what the test is for. It's
yeah,
not just get a pass.
yeah. They're ultrasonographer techs that do that, and they shouldn't be allowed to do that.
Well, and then the problem is accountability. We cannot sue for a baby that dies, unfortunately, in the womb in most states. So sadly, if you even know that that happened and that's a medical malpractice issue, you might have just no way to hold your doctor accountable. So it's just the end of your baby's life, you know?
Yeah, it's hard to do.
Yeah. But we have no plans to stop pushing. And I think that's what it's going to take. Like we said, we're just all going to keep meeting. And so feel free to let us know if you'd like to join us. Thank you so much, Dr. Collins, for
Sure.
all your wisdom. Is there any other advice or a quick tip you want to share?
Now we covered a lot of territory, and just keep educating the moms, and that's uh, a very good thing to do. You'll get results by doing that.
Yeah.
We'll have a couple of moms learn how to tell them I'm not going home. You keep me on that monitor, and you better be right about my baby being okay, or else.
Really,
You
that's the
know,
truth. I mean, you become a mama bear when you have your child here. So you should do that already in the pregnancy and consider it. You know, it is your job. You might have to fight for what you need. So if you feel wrong, if you feel your baby's different, just continue, and let us know. We can support you if you need any data or research to prove your point. But for most people, if you just say, I'm not comfortable with the change in fetal movement, and just tell them I'm very scared. I think something's gonna happen to my baby. They are not necessarily gonna just push you out the door if you're saying things
no,
like that. That's
no,
pretty
they can't do it. They can't push you out the door unless they have proof the baby's okay, and chances are they don't.
right. And last thing, I know you've sent me, but it's not being used very much, I think, yet, is the home monitoring options of.
Yes.
I don't think that's covered by insurance yet, of course, and doctors may or may not want to allow it. It depends on your doctor, but there are some things coming along which, you're working on. I just want you to go ahead and share why you think that might be some way to help with some of this.
But I think home fetal monitoring is eventually going to take hold because it's convenient for the mom, especially a mom that needs to have non-stress tests on a weekly basis. It prevents her from having to travel long distances. It's an accurate measurement. It's approved by the FDA to do home monitoring. So it'll catch on. The doctors just have to get used to the idea that it can be done by the mom. You still have this uh, old view that you can't do a good NST unless a nurse is doing it. And I know for a fact that's not necessary. Moms can do it all by themselves, and they can do it at home, and they can do it better. So they'll catch on eventually. Uh, just as the whole area of telemedicine, telecommunications, people are accepting it more and more. I mean,
Hmm.
look what they're doing with cardiac monitoring.
Right.
So they just got to get used to the idea. That's all.
And that's different, obviously, than a Doppler. So we
Yeah,
always discourage use of Doppler because the Doppler only checks the heartbeat only, and it will be, reassurance that your baby has a heartbeat, but then maybe the fetal movement is different and something else is going on and you don't go in, and that could be a big problem. So we definitely tell people don't use Dopplers at home unless it's just to kind of play with and hear your baby's heartbeat, but not as a sign of your baby being good or not.
right. It doesn't trend it. Unless it records it, trends it, it can't help you.
Well, even those, I had one because a friend of mine had it and she let me use it. It's like you don't really know what number should it be, and the thing doesn't always read right. So it's just kind of not, it's not very accurate, I think, at all. I mean, obviously, you're just hearing it in that
Well,
moment too.
not for testing. It's just good for locating the heart and knowing what the heartbeat is at that moment in time. But it,
Hmm.
it can't help you as far as the test goes.
Right. And with the home monitoring system that you were talking about, you were suggesting evenings too, which will be more accurate too, because they'll be done when these changes sometimes happen, right?
That's right. That's our point of view.
Hmm. Well,
Absolutely.
I'm open to it. I think we need innovation, and even if it's just like in addition to your weekly NSTs, this is going to happen, it gives you a little bit more, which I would love. More is better for me, which I know it's not like super popular, especially for the people who want to do natural birth and they don't want a risk of intervention. They say like, don't allow all this continuous monitoring because that's going to make your doctor give you a C-section, you know. And there's that whole culture of this birth world where they don't want babies delivered, but I think they're not thinking straight because it's like a doctor's not just going to deliver a baby for no reason. They will do it if they see something alarming.
Well, Edward Hahn was the inventor of the fetal monitor, and he invented it because babies were dying during labor, mainly of core compression. And this was his way of finding those babies. Uh, there's a nice article of him showing that in an old Life magazine, which I have the pictures of. I'll try to remember and maybe send it to you.
Mm.
So that's why the monitor came about in the first place, because babies were dying during labor.
And it's
And
very, very common actually that there's a high risk of stillbirth during labor.
yeah,
It's just insane to me to
so
think that you're like, we were having the baby and the baby died. And I know friends that had that happen. They were delivering their child and the baby got an issue, you know, at delivery. And it's so sad. Like that should be the last thing that's happening, especially if you're in the care of a doctor.
so why take such a valuable tool away? Just like ultrasound, it's an incredibly valuable tool. How would you else would you know what's going on without it? So everything in OB used to be a surprise. Well, let's see what we got. And you deliver the baby and then you'd see the problems. But now we have a way of finding the problems very early and maybe being able to do something about it.
Mhm.
One of the more amazing, innovative OB doctors in the world is Dr. Kypros Nicolodis at King's College. He's an amazing man, what he's done with some of these innovations. And OB needs to step up and realize they need to improve.
Well, yeah, especially in our country where we're almost dead last in improvement for stillbirth reduction. So we're
Yeah.
obviously not doing anything different all these years and decades. And, you know, all the same babies are dying for same similar reasons. So, you know, if that's not enough reason to try something new, I don't know what is.
Because our prenatal methods aren't good enough. And you're going to have to do more testing and more accurate evaluation in order for that to get better. And they got to be willing to do it and not so unwilling to innovate. OB is one of the worst specialties for innovation. Uh, they just don't do it.
Yeah, I think it's the most common thing for a mother who lost their child to be told that this was standard care, you know? Like, well, yeah, obviously your standard of care is poop. I'm not so sorry, you know? It
Yeah,
shouldn't have happened.
it doesn't cover the perimeter, you know, it
No,
only covers the core. It's not enough.
right. And I think it's because a stillbirth is less than 1%, it's still this mentality like, oh, it's pretty rare, you know? Like, yeah, whatever rareness, I don't care about that. That to me is, you know, very awful to say to a parent because my son matters, you know, it doesn't matter how many there were that
Yeah.
year, you know, but 23,000 is a lot. So we actually are going to do a big kind of march. We're calling the big push in Washington, D.C. on the day of pregnancy infant loss awareness, which is 10/15, October
Okay.
15th. And we're having at least as many as we can physically there. But the goal is to show, you know, we have 23,000 babies lost every year. So we're going to have that many empty strollers being pushed
Easy.
around,
Oh,
whether it's there or virtually, you know, you can do it in your hometown and send us a picture, but we want to show like this is a huge number. And if you don't even know what 23,000 looks like, we got 23,000 baby hats, the ones they give you when you deliver your baby.
yeah.
We're
Yeah.
going to show those there, you know, like this is 23,000, you know, because it needs to get in people's head. That's a big number actually, even if it's a low statistic number. It is a lot of babies that are dying and that could be saved. 65 a day. I mean, that's not a little bit. I go to sleep thinking about that, you know.
Well, invite Dr. Zahn to come to your march.
Yeah, we're talking to him, the president of ACOG, and discussing, you know, fetal movement education is very poor. They think that doctors are talking about this, but we have so many lost parents who will tell you otherwise that we never were told how to
No.
count kicks, what does it mean, when should you go in, you know, and if anything, they're giving
No.
misinformation too.
Yeah, no, they don't really like kid counts, to tell you the truth. So there's another study going on in England about baby's movements and kicks. I don't know what the end result of it is, but the people doing it don't understand it either. So uh, the best way to look at it is, what does your baby do at the beginning, and is it transitioning through behavior over time? And what does that feel like? And if it gets exaggerated, you got a problem.
Hmm. Yeah, either way, less or
Yeah.
more. So yeah, this is a great conversation. Thank you so much, Dr.
Well,
Cullen.
thanks for including me.
I
And I think
appreciate you. And you're
what
actually
you're
my
doing
first
is,
male guest. This is called
yeah,
womb wisdom, I call it. But I'm like, even though you didn't have a baby, you delivered many. So I think it's fair
I
enough.
feel like I've had babies.
You saw a lot of situations. I mean, you can never know what it means to be pregnant and how it feels, but you've heard it enough, you know. So I think your information is very valuable, and
Oh yeah,
especially,
I'm communed with pregnant women for sure. Yeah, I think
yeah,
what you're doing is great. It's really amazing to see what you've organized. So it'll work. You know, you'll succeed.
I think
Keep,
so.
keep going.
Yeah, it's kind of an obsession for me at this point. So I know people probably like, oh, she's doing this and that. Like, well, I cannot stop. I'm going to DC. I'm going, I'm marching. I'm meeting with all my senators. I am talking to all, anyone I can about it, what they can be doing different. We're actually erasing the internet of misconceptions soon. That's a big project we're doing with Count the Kicks and Kicks Count UK, and hopefully ACOG. I'm trying to get a meeting with them to get the right information out
Yeah.
about fetal movement on the internet, because the web is full of misinformation. So that's horrible, because if a mother worries at night, she Googles it, and then there's like, oh, it's fine. Just, do your kick counts or drink some juice. Okay, now my baby's moving. Oh, so I'm just freaking out for nothing, So we're going to try to update all the websites somehow, just give them the correct information. Hopefully they'll
Yeah.
replace their old outdated information. So we're working at every angle possible, because our babies are worth this time, they're worth this much energy. And I think that's what's really appalling about it, that it's been let go this long, and it's been allowed to be like, just, it's just statistics. It's just the odds, that was the one baby that was going to die today, 65, whatever. And to me, it's not right. You need to give it the level of importance, urgency, concern. This is a national crisis. There should be a national level of state of emergency of all of us dealing with this.
Well, if you can get across on that website that if you've noticed anything different, go to labor and delivery. If you can get that across, then
Yeah,
you'll definitely have the advantage.
right. I mean, that's pretty simple, and it sounds simple, but we also need the support of the doctors on the other end, receiving the patient and doing the right things, so it's a big, big thing. But yeah, definitely, we're clearly trying to communicate to the mothers and the parents, like, you guys have the power, so pay attention to movements and go in there and demand what you need. And, hopefully your baby will be fine, and, get to come home with your baby, which is the goal for everybody, right? That's why anyone becomes a doctor. And, we all want this. So I think we're going to get there for sure.
Yeah, well, I can tell you that I have had cases where we've prevented stillbirth, babies that were clearly getting into trouble, and we intervene. So I know it can be prevented. I know it doesn't have to happen.
Hmm. And that's kind of where we need doctors to understand that too, because I think there's a fatalism, of feeling of it's just going to happen. Like, we can't save them all.
Yeah, well, there is that thought process out there, and it needs to be corrected. Uh, the idea needs to be, okay, well, polio is inevitable. You're not going to do anything about it. AIDS is inevitable. You're not going to do anything about it. It's just not the right point of view. You're supposed to do something about it.
Mm-hmm. Well, we don't even have like a registry of all the stillbirth causes and things like that. So that's why we're working hard, like on the Shine for Autumn Act, which will have now proper data collected from each stillbirth and the causes, and have more trained pathologists, which we don't have enough to actually figure out
Well,
causes.
include in that they have a photograph of every baby.
Mm-hmm.
Every baby, cord, and placenta should be photographed at birth, where there's
One
this.
thing you mentioned too before is, like, even if you realize there's no more heartbeat, they rush to get the baby out, but they should do an ultrasound then first, get a good ultrasound of where the cord is, what's happening inside of there before you deliver. I mean, there's so many things that could be done to like get the proper information for us to now discover the cause. And I feel like they mess that up because they just want to get the baby out. You know, the
Yeah.
parents too, like, just get the baby out of me, you know, because we don't think, we're just freaking out that we have a dead child now in our stomach. So it's like, you know, we're panicked, and then they just, oh yes, you know, we're going to get the baby out, and I don't even know what they do on their end to kind of figure that out. But the immediate response from my doctor was, he didn't know. He said sometimes healthy babies just die, and I was like, you can't just tell a parent that immediately after the baby's delivered without even doing any research
Oh,
why my son died.
they weren't healthy. They weren't healthy in the first place. They were obviously having a problem. So I don't agree with that at all.
Yeah. So thank you so much, Dr. Collins. I won't keep you all day because
Okay,
I know
well,
your
thank
time
you
is
for giving me
valuable.
the chance to talk about these things.
Thank you. We'll talk more on Friday if you can make it still.
Okay, well, yeah,
Thank you.
thank you.
Thank you all for
You're
watching.
doing great. Okay.
Thank you, Dr. Collins. It was hard to end this conversation with Dr. Collins, as you can tell. I can ask him questions all day, and there's just so much knowledge out there for us. So I hope you enjoyed it, and we'll save it to listen to it again and again. Remember to share this episode on social media so you can help others in your circle grow their knowledge and have a better birth outcome. Remember that all the posts that we share and our episodes are not meant to be medical advice. We are simply trying to help you and inform you as you continue your pregnancy, but always remember that you should consult your provider if you have any questions or concerns. They're there to help you, and they are available to you 24/7, even if you have to go into the hospital or ER. Again, follow us on social media to continue up to date with our next episodes and our posts. And feel free to connect with us in the DMs. If you have any questions, we would be happy to be there for you. You are not alone. This is your community, and we hope that you will continue to watch our future and past episodes to continue to add to your knowledge as we interview birth workers, providers, researchers, and even people who have experienced different births, so that when you get to your birth, you'll be a little bit more informed and prepared for whatever comes your way. Goodbye for now.